is my duality of interest, and it is not easy to be original and not to repeat something that we have already heard, but I'll try to give you something new. And this is my outline, and I'll try to explain why we have to look for diabetic polyneuropathy and how to address the wide underdiagnosis, and just a final consideration on new guidelines. And diabetic polyneuropathy is a symmetrical and dependent sensory-motor polyneuropathy. In this definition, there is all the characteristics of this condition, and painful form is the form where it is present neuropathic pain as a consequence of the polyneuropathy itself. And in this epidemiological study in Italy, in secondary centers, diabetic outpatient clinics, and through a confirmed diagnosis of diabetic neuropathy and pure small fiber polyneuropathy and painful polyneuropathy using nerve conduction velocity and skin biopsy, we found a prevalence of 36% of diabetic polyneuropathy, and just a little less than half of those patients had the painful form, while a pure small fiber polyneuropathy was present in only 2.5%. And we know that diabetic polyneuropathy is the major predictor and determinant of foot ulceration, and is present in almost 90% of people with a first foot ulcer in a wide population in Europe. And of course, the presence of foot ulcer is a cause of increased mortality, but also even the presence of abnormalities in nerve conduction stadio monofilament, or in MNSI questionnaire, or in vibration perception threshold, is able to increase the risk of mortality by 72%, and also the risk of cardiovascular events by 65%. And I'd like to note that the painful form is worse compared to painless polyneuropathy. But the impact of painful form on the life of people with diabetes is not regarding mortality or cardiovascular morbidity, but also quality of life. This is a study from our group, where the presence of neuropathic pain was together with the female sex, was the greatest determinant of depressive symptoms, also when adjusted with other comorbidities. Neuropathy, we should care of neuropathy because it is a common complication and has consequences of quality of life and survival. And the presence of neuropathy identifies by itself a person at high cardiovascular risk, and the presence of neuropathic pain has an additional impact on survival, cost, and quality of life. How we can evaluate diabetic polyneuropathy using neuropathy symptom and signs scoring systems. functional psychophysical tests as quantitative sensory tests, functional objective tests, nerve conduction study, and morphological tests, skin biopsy and corneal confocal microscopy. And the national diabetological societies have an approach to the screening and diagnosis of diabetic polyneuropathy that favors the easiness and the accessibility. Just using simple clinical tests is enough for screening and diagnosis. And Italian recommendation also consider the opportunity to use structured scoring system as the MNSI system that include a questionnaire and examination. And in this study by the group of Eva Feldman, who introduced the MNSI, it is considered that the best cut point for an abnormality of questionnaire is 4 and an abnormality of examination is 2.5, but with a low sensitivity for the questionnaire. This low sensitivity of MNSI questionnaire is also confirmed by a study from Denmark, where the sensitivity was around 26%, but with a good specificity. And I'd like to notice that DM4 plus pain in the feet has a good sensitivity and specificity for painful neuropathy. The possibility to provide controlled and quantified stimuli standardized procedures is an advantage of quantitative sensory testing, in addition to the possibility to study also small fiber function not covered by nerve conduction studies. And recommendation introduced to the use of QST as a screening test for small and large fiber neuropathies, and also for monitoring over time of sensory deficits. But the recommendation by the Toronto Consensus consider also symptoms and signs to obtain a first level of certainty in diagnosis of possibility with symptoms or signs, probability with both, and confirmed diagnosis when symptoms or signs are confirmed by an instrumental study as abnormal nerve conduction or a skin biopsy or thermal thresholds. The electrodiagnostic studies are not needed, as also previously said, apart from the cases where an atypical presentation of symptoms and signs makes not certain the attribution to diabetic polyneuropathy of neuropathic signs and symptoms. And there is also a role for laboratory testing to exclude other causes of polyneuropathy, as very well described by Rodica, Pop, Busui. And there are also morphological studies for small fibers, skin biopsy and CCM, and I just consider the potential for large application in clinical screening programs with the new automated methodology. So evaluation of symptoms and signs remains the recommended screening modality for its diagnostic reliability and easy of use. There are new methods with the potential of large application, but with still limited access. one of a conundrum in the field of diabetic neuropathy is why half of people with diabetic polyneuropathy have pain and the other half not. And it is possible that genetics changes related to sex and gender, psychosocial aspects, or also metabolic abnormalities can play a role and can change the progress of polyneuropathy toward painless or painful form. It is now well recognized that it is not a problem of preservation of fibers, because as we showed 10 years ago, there is a link between the severity of sensory deficits and the development of neuropathic pain. In this study, the MDNS was the greatest predictor of neuropathic pain, with the relationship between the pain intensity and this score, as also previously noticed by Riaz Malik regarding CCM. And this association between severity of sensory deficits and development pain has been also confirmed by other authors. But what is neuropathic pain? Is the result of a maladaptive plasticity in the nociceptive system, with the possibility that pain is present also without stimulus, or is exaggerated according to the intensity of pain stimulus, or determined by non-painful stimulus. And this abnormality in the somatosensory nervous system can lead to different mechanisms of neuropathic pain that can be a peripheral sensitization, or a central sensitization, or a less active descended modulatory system. And the International Association for the Study of Pain has delineated the flowchart for the diagnosis of neuropathic pain, starting from the presence of pain that has to satisfy the characteristics of neuropathic pain, and should have a distribution neuroanatomically plausible. And in this case, there is a possible neuropathic pain. When there are also sensory deficit in the same area as pain, we have we reach the grade of certainty of probability. And when we have a diagnostic test that confirms the lesion or disease in the somatosensory nervous system, we have a defined neuropathic pain. And for the painful diabetic polyneuropathy, we should check for the characteristic of pain, for the regional distribution, for the sensory loss in a symmetric distal distribution, and we can also look for a defined diagnosis, but the level of probability should usually be sufficient to initiate treatment according to guidelines. But how we can identify the neuropathic pain of pain? Using the so-called screening tools SDM4 that include one question, a first question on the characteristic of pain, a second question on other neuropathic symptoms, and the third, the fourth question for the the doctor and for a examination in the same area as pain. And we documented some years ago that DM4 has a very good diagnostic performance, also when used only as interview at the cutoff of 3, with a very high specificity and a good sensitivity, but 20% of people cannot be diagnosed using the questionnaire. And there are also recommendations to measure the intensity of pain and also to measure the impact of pain on quality of life. And finally, pain diary and another questionnaire, patient's global impression of change, can be useful to assess the response to treatment of patients. So here we have the two diagnostic pathway in comparison and the 3 different levels of diagnostic grade of certainty. A development in the research in the neuropathic pain field is the attempt to define the pain phenotype, because any individual, according to the specific mechanism of pain that play a role in his neuropathic pain, may have a particular pain phenotype, and in this way it is possible to tailor the treatment of neuropathic pain according to pain phenotype and then to the supposed pain mechanism acting in that patients. And so there are attempts to sensory profiling based on QST and to derive pain mechanism as differentiation from sensory loss, peripheral sensitization from thermal hyperalgesia, central sensitization from mechanical hyperalgesia. And another development is to use bedside QST devices to define these sensory profiles and pain phenotypes. So how bring out the need, the presence of neuropathic pain that often is not recognized and also not referred by the patients. And the diagnosis of neuropathic pain is the first step in the diagnostic pathway and is a precondition for its effective management. You should start on the right foot and identify the pain to treat the pain. But we know that there is a large underdiagnosis of diabetic polyneuropathy. This is a study from Germany, but we have just heard from Riyad Malik that it is the same in Qatar and in the Gulf regions. So there is a wide underdiagnosis of diabetic polyneuropathy. This is true also in Italy. Just 1 out of 5 people with type 1 and type 2 diabetes have foot examination. So other speakers have cited these consensus recommendations and these algorithms, so I can go fast. I just mentioned the attention to DM4 for the screening of neuropathic pain and to the possibility to use scoring systems for symptoms assessment and for signs examination. and also to the criteria for the diagnosis of painful neuropathy, neuropathic pain in a plausible neuroanatomical distribution, distal symmetrical, but also the consideration that few cases can be pure small fiber neuropathy. And the last point is on implementation of guidelines, and the modality to increase awareness, improve education, emphasizing the role of patients, of healthcare practitioners, stakeholders, to train the staff, and also what Abtarani cited before, the inclusion of the screening for diabetic neuropathy and diabetic foot risk in an approach that combine the annual eye screening and also microalbuminuria screening. And this one-stop screening service is feasible, as a high uptake, and is well received by participants. And another initiative in France, in pharmacies, where pseudoscan was combined with medical history questionnaire and MNSI questionnaire, plus photos of feet, transmitted to a central diabetology unit, with a result in graduation of risk, and also recommendation for GPs, podiatrists, etc. So I'd like to conclude saying that innovative approaches might be required to address the wide underdiagnosis of diabetic polyneuropathy, and I thank you, my co-workers and colleagues, and thank you to you for attention.